Hi there everybody, we're gonna start with glomerulitis and glomerulopathy, and we're gonna start with a disease that manifests by a nephrotic syndrome. We're gonna start with the first of all with the minimal change disease, and on electron microscopy there is a fusion of what process, and the Hodgkin disease and NSAID use are the most common cause of secondary MCD, and the prednisone is the drug of choice for that disease. Second one is the focal segmental glomerulonephritis. The HIV reflux nephropathy are the most common secondary causes, and FGS frequently progress to end-stage renal disease. The membranous glomerulonephritis, spike and dump, are the pathological hallmark, and it's the most common cause of nephrotic syndrome in adults. Cancer, HIV drug are the most common cause of that. 25% of cases progress to ESRD. On immunofluorescence, the IgG and C3 granular deposit can be seen. Next one is the diabetic nephropathy, and the microalbuminuria is the hallmark for the incipient diabetic nephropathy. The AC inhibitor is the drug of choice for that. Increase in mesangial matrix results in two morphological patterns, the diffuse sclerosis, and the second one is the nodular glomerulonephritis, which give rise to the Campbell-Wilson idiopathy. The fifth one is the renal amyloidosis, and the characteristic green apple under the polarized light. The rheumatoid arthritis and multiple myeloma are the most common secondary causes. The lupus nephropathy type 4, or the diffuse proliferative glomerulonephritis, which characterized by carrying the worst prognosis, the wire lobe finding, and treated with a Prednisone. The next one is disease manifested by nephrotic syndrome, and we're gonna start with the post-infectious glomerulonephritis. The post-streptococcus glomerulonephritis is the most common form of that. A light microscope shows the diffuse proliferation of inflammatory cell, while on the other hand, on electron microscope, the hump, the characteristic hump, or the immune complex in the subepithelial space. PB control and diuretic will be the appropriate management for that disease. The rapid progressive glomerulonephritis type 1 has the anti-GBM antibody, which can clinically present as a Goodpasture syndrome. Type 2 of a post-streptococcal immune complex in almost 50% of cases. Type 3 or the ANCA positive type. The cyclophosphamide and prednisone are the drug of choices. Next one is the Goodpasture syndrome, or kind of type 2 hypersensitivity, a crescentic glomerulonephritis with linear deposition of IgG on IF. Apheresis, IV steroid, and cyclo are the appropriate management. Diffuse pulmonary hemorrhage is one of the typical findings in Goodpasture syndrome. Albert syndrome, defect in the alpha-5 chain, collagen 4. The X-linked is the most common mode of inheritance of Albert disease. Split and thickening of GBM is the pathological hallmark of the disease, and dialysis renal transplantation is the appropriate management of that. IgA nephropathy, the most common cause of glomerulonephritis worldwide. Cross-hematuria started within a day of upper respiratory tract infection, hence the name synpharyngitic is applied here. The Hennig-Schwann-Purpura, or the systemic form of IgA nephropathy, in addition to IBD, are the most common cause of disease associated with IgA nephropathy. Omega-3 may be useful. Last but not least, the MPGN, SLE, HPV, HCV, CLL are the most common cause of secondary MPGN. Type 1 associated with mesangial inner position, resulting in the characteristic tram tract. On the other hand, the type 2, or the dense deposit disease, a unclear tram tract appearance deposit of immune complexes within the GBM C3 is markedly decreased with elevation of C3 nephrotic factor. Thank you.